Good evening, and thank you so much for joining us for our latest clinical education webinar, Treating Moderate to Severe Acne with Oral Antibiotics in an Era of Good Antibiotic Stewardship. My name is Kim Montanarello from Visual DX, and I want to thank you for spending the next hour with us. Today's presentation will cover varying oral antibiotic choices available today and their differences. Comparisons between broad spectrum and narrow spectrum antibiotics will be highlighted. Pros and cons of different members of the tetracycline class of antibiotics addressed, and comparisons will be made between. As antibiotic resistance becomes more of a concern, how can acne patients be best managed if an oral antibiotic is needed? Before I introduce our presenter, I do have a few housekeeping notes. We encourage questions from the audience. So while you are all muted, we do hope you will submit questions through the Q&A box, and we'll get to as many as we can. Also, this webinar is being recorded and will be shared with registrants. Following the clinical presentation, we'll test your skills with a Kahoot quiz, awarding a prize to the winner. So you'll want to have that app downloaded. I'll put information in the chat for you in just a few moments. We also ask that you take our survey at the end to provide feedback. And my colleague, Mike Venanzi, will provide a demo of Visual DX at the end for those interested in staying on. Now I would like to present and welcome back our presenter, Dr. Emmy Graber. Dr. Graber is the founder and president of the Dermatology Institute of Boston, a private practice in Boston, Massachusetts. Dr. Graber treats a wide range of dermatologic issues and specializes in acne and cosmetic dermatology. She's currently an affiliate clinical instructor at Northeastern University and has extensive experience teaching students of all types. With that, Dr. Graber.
Thanks, Kim. Welcome all to this presentation. And tonight, as Kim mentioned, I'll be talking about treating moderate to severe acne with oral antibiotics in an era of good antibiotic stewardship. First, my disclosures. The agenda for tonight, we'll talk about the whole tetracycline family. We'll talk about each member of the tetracycline family, and we'll talk about the mechanism of action of these antibiotics. We'll go over some of the guidelines for treatment with oral antibiotics and talk about some very important considerations in antibiotic resistance. I'm going to highlight the difference between broad spectrum and narrow spectrum antibiotics, and I'll make some comparisons amongst the members of the tetracycline family: Sarecycline, Minocycline, Doxycycline, and Tetracycline. If after tonight's talk you're interested to learn more about treating acne and rosacea, feel free to register for 2 complimentary webinars that I'm hosting just on acne, acne scarring, and rosacea. You can register at armmeeting.com, armmeeting.com. So let's get started with looking at the AAD clinical guidelines for the management of acne. And these guidelines are about 5 years old now, but you can see this is broken down. It's a panel of experts that came to a consensus as to how acne should be treated. And you can see recommendations here for treating mild acne, moderate acne, and severe acne. And for both moderate and severe acne, the expert panel suggested as first-line treatment, including oral antibiotics. Now, these guidelines were older, so which oral antibiotic was not exactly specified, but the guidelines did mention those of the tetracycline family. But oral antibiotics should be a mainstay in treating moderate to severe acne. Now, as dermatologists, we prescribe a lot of antibiotics. And this was a study that looked at trends in antibiotic prescription amongst different specialists. And the finding was that dermatologists prescribe more antibiotic courses per clinician than any other specialty. And really, we should be aware of this. And although antibiotics are important, and we'll talk about what role they play, we have to also consider antibiotic stewardship. And I'll talk to you a little bit more later about exactly what good antibiotic stewardship is. Which antibiotics are we as dermatologists prescribing a lot of? And this data is a bit dated, but you can see from this pie chart that by by far, we're prescribing mostly tetracycline antibiotics of the tetracycline family, not just tetracycline itself. So almost 70% of the antibiotics that we write for are within the tetracycline family. So the tetracycline family are the most frequently prescribed and the most widely studied for acne. They're the only class of antibiotics with FDA indications for acne treatment. All of the tetracycline members, tetracycline, doxycycline, minocycline, sarecycline, are effective for treating acne. And you can think of the tetracycline family as different generations. So you have your first generation, the earliest member of the tetracycline family is tetracycline itself. The second generation members are doxycycline and minocycline, and the newest third generation member is Sarecycline. So the tetracycline antibiotics as a class are on the older side. So doxycycline was FDA approved in the 1960s, minocycline in the 70s, and then there were different brand iterations of doxycycline and minocycline that were approved. And then Sarecycline was FDA approved in 2018. So it had been a big gap of time between the approval of minocycline and then until we had this newer third generation member, Sarecycline. So here's a depiction of the different members of the family, and you can see their different chemical structures. So on the left, the first generation tetracycline, and that was FDA approved in 1953. And then the second generation here, doxycycline and minocycline. And then the third generation, Sarecycline. And you might notice right away that the difference here with Sarecycline is that it has this C7 chain on it. And that is very important. And we'll talk about that as the presentation continues. But remember, Sarecycline, it's the newest member, and it also has this C7 chain, which is very different, makes it very different, makes it have some unique properties over the other tetracyclines. Now, Sarecycline is also what we call a narrow spectrum antibiotic. And that's also a really key point of this presentation. You should understand the difference between broad and narrow spectrum antibiotics, and I will go over that in detail. The first and second generation antibiotics in the tetracycline family, tetracycline, doxy, mino, those are broad spectrum antibiotics. Sarecycline is a narrow spectrum antibiotic. So the whole family generally has a very similar mechanism of action, and we'll talk about some differences that actually Sarecycline has. But in general, all the members of the tetracycline family have both antimicrobial effect on C. acnes, and they have anti-inflammatory mechanisms. So all of them both antimicrobial and anti-inflammatory actions. How do they have the antimicrobial effect? Well, it's by binding to the 30S subunit of the bacterial ribosome. And you can see in the depiction here, the tetracycline member antibiotic is depicted here by the red X, and it binds to the 30S ribosomal subunit. And this prevents the transfer RNA from incoming and binding to the ribosome. And then protein synthesis is ceased, and this halts growth and replication of the bacteria. So you can think of the tetracyclines as sitting here on the 30S ribosomal subunit and blocking the incoming transfer RNA. Now, Sarecycline, I mentioned it has this different C7 chain, and this does impart a different mechanism of action. It still does block the transfer RNA from coming in. But in addition to that, there are studies that show that Sarecycline interacts directly with the messenger RNA. And I like to think of it as that C7 chain arm just reaching down and really integrating with the messenger RNA. And that is depicted in these 3D images here, which is part of a beautiful publication demonstrating the unique mechanism of action of Sarecycline. Now, because this C7 arm reaches down into the messenger RNA and kind of has this, I think of it as a more intricate attachment to the ribosome, this may make Sarecycline a more potent protein synthesis inhibitor compared to the other tetracycline members. So they all block the incoming transfer RNA, but unlike the other tetracyclines, this C7 moiety that's on Sarecycline extends down to the messenger RNA. So slightly different mechanism of action. I did mention that all of the tetracycline members also have some anti-inflammatory effects, and these anti-inflammatory effects could occur in three main different ways. They could decrease inflammatory cytokines such as interleukin-1, interleukin-8, TNF-alpha. Secondly, the second anti-inflammatory action that the tetracyclines have is that they downregulate proteinases such as the MMPs or matrix metalloproteinases, and these really strongly contribute to acne formation. Thirdly, the third big anti-inflammatory mechanism of the tetracyclines is that they block and scavenge the reactive oxygen species and prevent oxidative damage to the cellular macromolecules. So keep in mind that tetracyclines have both antimicrobial and anti-inflammatory effects. So I'm talking all about antibiotics, and the AAD guidelines recommend oral antibiotics. But we've also heard lately, wait, should we be so quick to prescribe antibiotics? Now, there is this era of antibiotic stewardship. And what does that mean? So the CDC has really stressed antibiotic stewardship. And this is an initiative to promote the appropriate use of antibiotics where patients receive the right dose of the right antibiotic at the right time and for the right duration. So we'll talk about exactly what that means. Now, more specifically, the CDC and some other agencies have also come out and said that they really suggest, whenever possible, using a narrow spectrum antibiotic rather than a broad spectrum antibiotic. As I said, the AAD guidelines do recommend an antibiotic. Now, so they were suggested as first-line treatment. Also in the AAD guidelines for using an antibiotic, they did suggest that they be used not as monotherapy, but in conjunction with a topical retinoid and a benzoyl peroxide product. Very important. It also is really important to use these topicals so that you can, whenever possible, shorten the duration of antibiotic use. You don't want to have your patients on antibiotics for years on end. Talking to them up front about the idea that this is not going to be a long-term medication that they're going to be on is very important. And using that topical retinoid makes it so that when you stop the oral antibiotic, they will still have continued improvement of their acne. Then using benzoyl peroxide with oral antibiotics is really important because it prevents the development of resistance. The guidelines also suggested shortening the duration, if possible, of time that an antibiotic is used, ideally 3 to 4 months. I can tell you that's always a goal of mine in clinical practice. That's not always possible. I have a lot of patients who are on oral antibiotics and have to be on them for longer than 3 to 4 months, but that should be the goal. There was no consensus from the AAD group as to whether the oral antibiotics should be stopped abruptly or gradually reduced in dose. There was also no guideline addressing retreatment with oral antibiotics for acne flares subsequent to the initial course of antibiotics. Let me also point out that with the guidelines, we broadly suggested as a work group oral antibiotics, particularly the tetracyclines. The guidelines came out in 2016. At the writing of the guidelines, the only choice that we had for acne were broad spectrum antibiotics. Our narrow spectrum player, Sarecycline, did not get FDA approved until 2018. And so we did not address that in the AAD guidelines. There was just a recommendation for oral antibiotics. But keep in mind that since then, the CDC has come out saying whenever possible, in this era of good antibiotic stewardship, it's best to choose a narrow spectrum antibiotic whenever possible. So which types of patients do I prescribe antibiotics for? I keep mentioning the guidelines, and moderate to severe acne are the patients that we should be prescribing these for. Well, there are some other types of patients that I also prescribe antibiotics, oral antibiotics for. There's the patient who tells you they won't be compliant with topicals. They don't want to use topicals. And sometimes when I'm talking to patients, I'm getting kind of a side look as I'm telling them to rub a cream on their face or on their back. And I'll ask them, I'm just very blunt about it. I say, if I give you a cream or a gel to apply to your skin, are you going to use it? And sometimes they'll say to me, no. So, you really, if a patient is not going to be compliant with topicals, it might be a good patient, even if they don't fit the moderate to severe category of acne, to use an oral antibiotic. That's how I do it. Well, also patients who have acne that covers a wide surface area, such as their truncal region, because it is hard to apply a topical all over to the chest, to the back, to the face. I mean, this picture here, this is a patient I wouldn't call this severe acne. There are definitely several lesions, but certainly it's not approaching severe in my mind. But for patients that just aren't going to apply a topical agent to a wide surface area, I'll consider an oral antibiotic. Also for patients who maybe their acne is not the worst, and I'm looking at it and thinking, well, I see it. It's not terrible. I think we can get it better with topical agents. But for patients who really wanted their acne better yesterday. So patients who need a fast improvement, patients who have an event coming up, or they're just, psychologically very bothered by their acne and we need it better sooner rather than later. I have a lot of patients too, who maybe they're candidates, maybe it's a female and they're candidate for an oral hormonal agent, but those are very slow to kick in. The antibiotics are a lot faster. The oral antibiotics are in general. And in general, they're faster than the topical treatments that often require 8 weeks. So as a summary slide for using antibiotics for acne, don't use them as monotherapy. Combine it with a topical benzoyl peroxide product and a topical retinoid. Aim for 3 to 4 months of use. I know that's not always feasible, and then stop. Communicate the plan with the patient up front so that they know it's not going to be something that they're going to be on forever, and also encourage them to use the topicals with their oral antibiotic. Now let's switch gears and let's talk about antibiotic resistance. Why is it so problematic? So when a bacteria becomes resistant to an antibiotic, the antibiotic will no longer work to kill or inhibit that bacteria or that infection. And even if you're thinking, all right, well, so what if one bacteria becomes resistant to an antibiotic? Well, the bacteria are tricky. They'll spread their resistance genes to nearby bacteria, even to different types of nearby bacteria. So they have these mobile DNA strands called plasmids and transposons, and they can move these DNA strands from one bacteria to their neighbor bacteria. So it only takes one bacteria to become resistant for it to spread to other bacteria. Now, we see resistance to antibiotics most commonly when the antibiotic is used for a prolonged duration, meaning years, or if the antibiotics are stopped and started repeatedly, or if broad spectrum antibiotics are used. So dissimilar classes, meaning the tetracyclines compared to the macrolides and the cephalosporins, and even antibiotics within the same class. So the members of the tetracycline family, Doxy, Mino, Sarecycline, can have varying propensities for resistance. There are rising numbers of Cutibacterium acnes resistant strains in all areas of the world. This is not a problem that is just in the United States. If you have a patient who is failing their topical or oral antibiotic, suspect that they are resistant to it. They may have a strain of Cutibacterium acnes that is resistant to that antibiotic. So this is a summary of some data that was presented several years ago now, but looking at resistance C. acnes resistance to different antibiotics in different countries. And so the top line, this was an older study, but so this was many years ago, 1983. Already in this particular study, 57% of the Cutibacterium acnes isolates were resistant to doxycycline. And you can see, the numbers, they vary from country to country in these different studies, but they're high. There's a lot of resistance, bacterial resistance to oral antibiotics. I'm going to show you a more recent study, and this is out of Jordan. It was just published last year. And I kind of circled the highlights that I want you to focus on here. And you can see on the left here, doxycycline, tetracycline, erythromycin, clindamycin, and look at the percentage of C. acnes isolates that were resistant to those antibiotics. So 37% of the C. acnes isolates were resistant to doxy. That means if you gave those patients doxycycline, it wouldn't work for their acne. Tetracycline, erythromycin, clindamycin, very high erythromycin and clindamycin, over 50% of the C. acnes strains were resistant to those antibiotics. Now, how does a bacteria like C. acnes become resistant to an antibiotic? So I'm going to go over two mechanisms in which C. acnes or other bacteria may become resistant to members of the tetracycline family. The first way that they can become resistant to a tetracycline member is by kind of kicking the antibiotic out of the bacterial cell. And this is with an efflux pump. And you can see in the diagram here that antibiotic is depicted by the purple squares, and the efflux pump is the red transmembrane pump there. So the antibiotic will come into the bacteria, and the efflux pump will kick it right out so that the antibiotic can't even do its work by binding to the 30S ribosomal protein, ribosomal subunit. So the second way in which bacteria like C. acnes can develop resistance to the antibiotic is through a ribosomal protection mechanism, so that the antibiotic can't even bind to that 30S ribosomal subunit and exert its mechanism of action. Now, these mechanisms vary slightly whether you're looking at tetracycline, doxycycline, and minocycline versus Sarecycline. And this does have clinical importance, so stay with me here. So when we're thinking about the first and second generation members of the tetracycline family, tetracycline, doxy, and mino, you have in here your bacterial cell. You can think of it as Cutibacterium acnes. And the tetracycline, doxy, or mino is kind of coming into the bacteria to do its job. It can't bind to the ribosome, and it's getting kicked out of the bacteria by the efflux pump. So this bacteria is resistant to the tetradoxy or minocycline. It just kicks the bacteria right out of the bacterial cell, and it's developed some protection mechanisms at the ribosomal level. Now, Sarecycline is a little bit different. When you have the Cutibacterium acnes and the Sarecycline working, the Sarecycline comes in and it can't get out. So then it can go to the ribosome and do its job and inhibit the bacteria. So why is Sarecycline different than the other tetracycline members? Why can't this C. acnes develop resistance to the Sarecycline? It comes back to the chemical structure. Comes back to this C7 moiety on the Sarecycline. It helps to overcome these resistance mechanisms that the bacteria may develop. So this is really important. And there are studies that have shown that C. acnes strains display a very low propensity for the development of resistance to Sarecycline. The findings were so strong that it even led to a label change on Sarecycline just last summer. Sarecycline is actually the only oral antibiotic approved for acne with a low resistance claim on its label. So really important clinically, because if the bacteria can't develop resistance to the Sarecycline, it will continue to work, and you won't have those therapeutic failures due to resistance. So which antibiotic do I prescribe for my acne patients? Well, I've done it differently over the years. And, every patient has different needs. So there's no one set recipe for treating every single acne patient. But I can tell you, when I was a resident 15 plus years ago, for my acne patients, moderate to severe acne, I was prescribing a lot of tetracycline. It was inexpensive. It was easy to get for patients. But then, tetracycline started to become unavailable, as is the case largely in the United States now. So then I started to prescribe more doxycycline for my patients. And then I ran into some problems. The big problems that I have with doxycycline, and I'll show you some data to support this in a little bit, but it's the photosensitivity issues and the gastrointestinal upset that patients often experience on doxycycline. This is a patient of mine who I thought I had told him about that he could sunburn very easily on doxycycline, and he went out wearing shorts, sat at a ball game, and got a horrible sunburn on doxycycline. So photosensitivity is a big problem with doxycycline. Gastrointestinal upset, I was hearing about a lot. So I thought, okay, years went by. I thought, you know what? I'm going to switch to minocycline. I can't handle this photosensitivity, this GI upset. I'm going to switch to minocycline. And then I started seeing some new problems. A lot of patients were coming in complaining of vertigo. I would have an occasional patient who would have serum sickness, a lot of patients with headache, and occasionally patients would come in with this hyperpigmentation. This is a great photo of this blue-gray hyperpigmentation, which we'll talk about a little bit more, that you can see sometimes with minocycline. So then I said, you know what? I'm going to try to just stop prescribing antibiotics. I'm going to use my oral hormonal agents. I'm going to use isotretinoin, but really that's not enough for patients with acne. There are patients that need oral antibiotics. Your patients who won't be compliant with topicals. Your patients who maybe have milder acne, but it's covering a broad surface area and they don't want to apply a topical all over that surface area. And the patients who want their acne better right away, as soon as possible. So then I started prescribing more Sarecycline. And I keep mentioning this, but I haven't really dove into it yet. What does narrow spectrum mean? So Sarecycline is, as I said, our only tetracycline member that's a narrow spectrum antibiotic. On the left, you can see a depiction of what the broad spectrum antibiotics and how they generally work. They inhibit many types of bacteria throughout the body. They are indiscriminate in the bacteria that they inhibit. So we're targeting C. acnes with them, but we're getting a lot of collateral damage. They're affecting bacteria in the gut, in the upper and lower intestine, in the stomach, maybe in the aerodigestive tract. With narrow spectrum antibiotics like Sarecycline, we're only targeting a limited number of bacteria in specific locations, such as the skin. So if at this point you're thinking, I don't care about resistance, I think, it's not real, I don't care, you should care because your patients care. And if they haven't come in asking you about it yet, they will. I know I'm hearing it a lot from my patients. If I even utter the word antibiotic, they're asking me a lot of questions. And these are just a few headlines from the lay media. I mean, look at this, NBC News, super acne, drug-resistant zits on the rise. In Vogue, all you need to know before using antibiotics to treat acne. The New York Times, does the gut microbiome ever fully recover from antibiotics? BBC News, antibiotic resistance is a big threat to health. And again, in the New York Times, making sure our antibiotics remain potent. So patients are reading these things and they're going to be asking you about it. So I just mentioned the human microbiome, and that is, we're going to get into this next topic. What is the human microbiome and how do the antibiotics that we choose affect it? So living on and in the human body, there's tons and tons of microbes. They might be viruses, bacteria, fungi, all part of our normal flora. So collectively, all these microorganisms form the microbiota. The microbiome refers to the microbiota plus their genes. So a lot of times microbiota and microbiome are used interchangeably. We'll use microbiome here. So the microbiome is essential in the development and regulation of many things: immunity, nutrition, digestion, hormone secretion, and inflammation. Of the over 100 trillion microbes that exist in our bodies, about 80% of them live in our gut, our gastrointestinal tract. So microbial dysbiosis is a change in the structure or configuration of the gut microbiome, which causes the gut homeostasis just to go out of whack. And when this happens, there can be associations with a lot of different diseases, such as obesity, diabetes, autoimmune diseases, neurological disorders, allergies, and inflammatory and infectious diseases. So in this schematic, you can see exactly what I'm referring to. So in gut homeostasis, you have the microbiome with lots of different types of organisms. They're all living happily together. The barrier is intact, and this is depicting a functional gut barrier. And then there's an immune response on the other side of this barrier, which is very tolerant. In dysbiosis, when there's a change in the types and the numbers of bacteria that are in the gut, there's increased susceptibility to pathogens, there's a defect in the normal barrier, and there's a dysregulated immune response. So you might think to yourself, okay, well, I'm not prescribing these antibiotics to patients forever. If I'm keeping it to 3 to 4 months, is this really having an effect? Yes. And this, I think, is so interesting, this study. It showed that even short-term use of an antibiotic, of a broad spectrum antibiotic, a 7-day course, that's it, can alter the gut microbiome for up to 2 years after treatment. So you can see in this image at the start on the left, you have this microbiome with all different types of bacteria that are coexisting together and taking care of the microbiome, making it healthy, having a tolerant immune response. Antibiotic treatment is initiated, maybe even just for 7 days. And it totally changes the types of bacteria, the ratio of bacteria that are in the gut. And that change continues for up to 2 years after the antibiotic has been discontinued. So really, you're not just, if you're using a broad spectrum antibiotic, you're not just affecting that patient's gut and gastrointestinal health while they're on it. It might even be a longer term problem that you're inflicting on them. So when we change the diversity of the gut bacteria and their selection for intrinsically resistant bacteria, there are all types of things that can go wrong in the body and things that can happen. There's a compromised immune system homeostasis. There's increased susceptibility to infections, accumulation of antibiotic resistance, and a dysregulated metabolism. So tetracycline, doxycycline, minocycline, those are all broad spectrum antibiotics. They do have that impact on the gut. They cause dysbiosis. Sarecycline is more targeted. It does not affect those gram-negative bacteria the way the broad spectrum antibiotics do. And let me show you the proof. So this is from a study in 2019 looking at the MIC, or minimum inhibitory concentration, of different antibiotics, doxycycline, minocycline, and Sarecycline. The MIC is the minimum amount of an antibiotic required to inhibit the growth of the microorganism. So the higher the MIC, the lower the antimicrobial activity. So if we look at this chart on the right, where Cutibacterium acnes is, see very low bars, very low MICs for doxycycline, minocycline, and Sarecycline. This means that they all have high antimicrobial activity against Cutibacterium acnes. Now, all the other organisms that are listed here to the left of Cutibacterium acnes are gram-negative organisms. You can see there's a big difference here amongst the oral antibiotics. There are much higher bars or higher MICs for Sarecycline, meaning there's much lower antimicrobial activity against those gram-negative organisms for Sarecycline than for doxycycline and minocycline. So Sarecycline is solely FDA approved for treating inflammatory acne, and it was developed specifically as a narrow-spectrum tetracycline antibiotic for the treatment of acne. It's the only tetracycline antibiotic that is approved for patients as young as 9 years old, and it's the only tetracycline with reported efficacy data on truncal acne. Patients only take it once a day. There's weight-based dosing, and conveniently it can be taken with or without food. And the side effect profile is really very low, and we'll get into the details of that, but a low percentage of gastrointestinal side effects and really low rates of phototoxicity or vestibular side effects. As I mentioned, it is dosed based on your patient's weight. There are three tablet strengths, 60 milligrams, 100 milligrams, and 150 milligrams. And you can see the chart here, how it's dosed based on the size of your patient. It can be taken with or without food. So these are the efficacy, this is the efficacy data for Sarecycline, and these are the results of a phase 3 clinical study. And this is looking at the percent change in inflammatory lesion count of Sarecycline, which is the dark blue line, versus placebo, which is the light gray line. Now, and we talked about our patients wanting their acne better quickly. And that's why for me, a lot of times I will choose an oral antibiotic for those patients. Sarecycline had significant improvement over placebo as early as week 3 in improving inflammatory lesions. So that's really great. So earlier than a month, Sarecycline will have significant improvement. Sarecycline also demonstrated improvement in non-inflammatory lesions a little bit later by 6 weeks, but also good for non-inflammatory lesions. So you don't have to think of oral antibiotics as just for inflammatory lesions. And these are some of the images of the patients who were in that study. On the top, a slightly darker skinned patient, baseline at week 3, already a remarkable improvement, and really good by week 12. And on the bottom, skin type 1, really, I mean, gosh, that improvement by week 3, if this were my patient, I would be overjoyed, and I think the patient would be as well. So we mentioned the gastrointestinal adverse events of a lot of the oral antibiotics. What did the data show for Sarecycline? Well, these were the studies here are comparing Sarecycline in the dark blue. The light gray bar is placebo. So Sarecycline, 3.2%, placebo slightly less, but still really low, well under 5% for the gastrointestinal side effects. There have been no head-to-head studies comparing comparing Sarecycline to any of the other broad spectrum oral antibiotics. However, this was recently published just a few months ago, and it's a great systematic review on the oral tetracyclines, and I would encourage you to read it. And this looks at the data that is available for the different tetracyclines. And this is a summary slide of the findings of this systematic review. If you look at the top here, so gastrointestinal events, comparing Sarecycline here to Doxycycline, you can see it highlighted in yellow. So in general, in the studies of Sarecycline, nausea, vomiting, diarrhea, well below 5%. Whereas the studies for Doxycycline, a lot of times in most of the studies, it was much higher. Some studies as high as 25%. Now, vestibular events, so things like headache, dizziness, tinnitus, when you look at Sarecycline, really very low. When you look at something like Minocycline, the vestibular events and CNS events, really high, above 10%, 17%, and acute vestibular events were around 10%. So much higher for Minocycline, and we'll talk about why that is shortly. Now, I mentioned that sunburn, photosensitivity can be such an issue, and that was an issue that I had on occasion with Doxycycline. And studies have shown really high photosensitivity rates with Doxycycline, whereas with Sarecycline, lower than 1%. So that is very encouraging, much safer for our patients in the summertime. So let's talk about Minocycline. Let's go back and talk about Minocycline, one of the second generation members. It's the most lipophilic member of the tetracycline family. It easily crosses the blood-brain barrier. And this is why patients on Minocycline have more frequent vestibular side effects than with some of the other tetracyclines. Minocycline dosing is often weight-based in order to reduce the likelihood of some of these vestibular side effects. It has been postulated to have better penetration into the pilosebaceous unit than the other tetracyclines because it is lipophilic, but this theory has never been proven to translate into superior clinical efficacy over any of the other tetracyclines. Minocycline is plagued with some problems such as skin hyperpigmentation, serum sickness reaction, drug-induced lupus. This is another study. I just want to show you briefly the bottom line. We mentioned the blood-brain barrier penetration. This study showed that Sarecycline's inability to cross the blood-brain barrier compared to Minocycline's ability to cross the blood-brain barrier corresponds with Sarecycline's lower lipophilicity and may explain why Sarecycline has a very low rate of vestibular adverse events. So I mentioned the hyperpigmentation that may be a problem with minocycline. There are 4 different types of this blue-gray hyperpigmentation, and it occurs in different locations on the skin. Sometimes it's even more pronounced in sun-exposed areas, whereas other times it might be more pronounced in scars or on mucosal surfaces. It most often occurs with prolonged use of minocycline, so more than a year, which is uncommon. However, it has been reported even with short-term use. So here are some images of what this blue-gray hyperpigmentation may look like. You can see it on the cheek here in this patient who still has some active acne lesions, and also on the shin of another patient. So again, in the gum line even, and on the lip too. Minocycline serum sickness can also be a rare occurrence, but it does happen. It's marked by urticaria, myalgias, arthralgias, fever. It happens just days after starting minocycline, very quickly after minocycline is started. Subsequent exposure to minocycline can result in even faster and more severe reactions. So once a patient has serum sickness to minocycline, they should never take it again. Doxycycline has been used in varying doses to treat acne. There are some that claim that using a low dose may just have an anti-inflammatory effect. However, there is some new evidence that suggests that even low dose doxycycline may promote resistance. Gastrointestinal side effects are frequently reported with doxycycline, but they oftentimes vary depending on the version of doxycycline and the dosage that's prescribed. And what I mean by GI side effects, nausea, reflux, vomiting, diarrhea, it really should be taken with food and water, and patients should not lie down for an hour after taking it because that can increase the likelihood of reflux. Absorption is decreased though, however, when it is taken with food, up to 20%. When I have patients on doxycycline, I tell them to take it with food. I don't know that the decreased absorption has any clinical meaningfulness in acne efficacy, but it is one that I would, if you're going to use it, I would highly recommend that patients take it with food. Doxycycline esophagitis is more likely to happen if they take it without food. And this is an esophageal injury that's been reported with almost 100 different drugs. However, antibiotics have contributed to almost 50% of these cases, and doxycycline alone has contributed to 27% of all of these cases. So yes, if you're going to use it, food and water, and do not lie down for an hour. There are some, and I'm just going to show one recent study on this topic, but there are several studies now that are suggesting that some of the oral antibiotics, particularly the broad spectrum antibiotics, may be associated with a higher risk of inflammatory bowel disease. And this was a large retrospective cohort study that found that the tetracycline class of antibiotics, especially doxycycline, may be associated with the development of inflammatory bowel disease, particularly Crohn's disease. So another thing to be a little bit cautious about if using a broad spectrum antibiotic like doxycycline. The photosensitivity, it can happen very frequently in patients. It is dose dependent, especially in those patients that are on higher doses. The first generation member of the tetracycline family, tetracycline, I mentioned at the beginning that I prescribed this many years ago, but in recent years, there's been a really short supply of tetracycline. And now there's really only one known manufacturer of the oral form. If you are going to use it for patients, it has to be taken on an empty stomach, meaning 1 hour prior to eating or 2 hours after a meal, just to make sure that there's adequate absorption. Common adverse events include phototoxicity and gastrointestinal upset. Pseudotumor cerebri is seen with all of the tetracyclines, but it hasn't yet been reported with Sarecycline. Fortunately, it is very uncommon. It's an increase in cerebral spinal fluid pressure. It clinically is marked by a headache with blurred vision, oftentimes a headache that increases with coughing. It is treatable. It requires quick ophtho consultation. And on exam, they'll see papilledema. And so they need to have an eye exam to diagnose it. And it needs to be treated right away, oftentimes with a lumbar puncture. So if you suspect this in a patient taking a tetracycline, you should have them see ophthalmology right away. What about using tetracyclines in pregnancy and in lactation? So none of the tetracyclines should be taken during pregnancy. There's a risk of tooth staining and bone inhibition. Now, with lactation, the American Academy of Pediatrics lists tetracycline as the tetracyclines as compatible with breastfeeding for short-term use. However, they don't define what short-term use is. I would not recommend tetracycline for acne in pregnant or lactating patients at all. So how do you choose an oral antibiotic? So they're all very similar in that they are effective for acne. They all have been proven to be effective for acne. Consider keeping your duration short, rather than, we're talking about months, not years. Use it in conjunction with a benzoyl peroxide and a topical retinoid. Consider resistance issues. Practice good antibiotic stewardship. Know what that means. Contemplate using a narrow spectrum over a broad spectrum antibiotics so that you can follow good antibiotic stewardship. Judge the pros and cons of the different side effect profiles of all the different members of the tetracycline family so that you can adequately counsel your patients. If you'd like to learn more about resistance and the use of antibiotics in acne, I would encourage you to read the 3 publication series that has been published by the AARS in the Journal of Clinical and Aesthetic Dermatology. And again, thank you for your attention. If you would like to learn more about acne and rosacea and acne scarring, I'm going to be hosting 2 complimentary virtual meetings on these topics. We have a great panel of speakers lined up, and you can register for free at armmeeting.com. So armmeeting.com. Thank you so much for your attention.
Thank you so much, Dr. Graber. We do have a few questions and we have a little time, so I'm going to tee up some. And first one is, do you ever use Sarecycline for rosacea patients?
Yeah, that's an off-label use. There is one study that was recently published showing that it may be effective also for rosacea, particularly papulopustular rosacea. I have, and again, it's off-label, but I have found it to be helpful for rosacea.
Do topical antibiotics have similar resistance patterns as the orals?
Yeah, that's a great question. So I showed that one slide that a lot, when we think of topical antibiotics, we think of the older members, such as topical clindamycin, topical erythromycin, and they have very high rates of bacterial resistance to those older topical antibiotics. Topical minocycline is a newer player on the market, and it is a little bit different in that it can lessen the likelihood of resistance developing because it acts outside of what's called the mutant selection window of bacteria. So a little bit different. It also has a labeling on one of the newer foams for that it has there's lower resistance to it. I think I don't put the topical and the oral antibiotics to compare them. I don't think they're the same. They're different for different patients. There are some patients who just prefer topicals, and then you would choose those. And there are a lot of patients who want an oral antibiotic. I don't really think you can compare one topical product to one oral product.
Oh, that was on mute. Sorry about that. What is your experience with TMP, SMX in acne and skin hypersensitivity reactions?
Yeah, so this person I think is referring to trimethoprim sulfamethoxazole, which I rarely use for acne. There are some reported side effects to this medication that I think the registrant's asking about, such as dress syndrome or Stevens-Johnson syndrome, very severe conditions that we want to avoid. I don't use that medication for acne. I think I've probably prescribed it once or twice for acne in the last probably 10 plus years. There's just not the data that there is for the oral tetracyclines for use in acne.
And let's do one more question. Let me see. What side effects do you discuss with your patients when starting Sarecycline?
Yeah, so I tell them it can be taken once a day with or without food. I tell them that stomach upset, gastrointestinal issues are very uncommon, but possible. And I do tell them, especially for my female patients, if they do become pregnant, that they should not take it, or if they're trying to conceive, it's probably not the best option, as are any of the tetracyclines. But really, I have very little concern and very little that I have to counsel patients on. That's about it.
Well, I want to thank you so much for a wonderful presentation on acne and all the different treatments that are available. And again, thank you all for participating. What we're going to move now to is the Kahoot. So I'm going to share my screen. And as I always say, the best thing to do for Kahoot, if possible, is to have two devices. Use your phone and use a computer if possible, so you can see the questions and then answer on your phone. So the game pin is on the screen right now, 4516322. So we'll just wait just a couple minutes to get people signed in. We're going to provide a $100 Amazon gift card to the winner. So hopefully you were paying attention, and we will again welcome everyone who can play today. A couple housekeeping notes again while we're waiting for people to log in. We do have an upcoming webinar after this. I'll share in 2 weeks again about AK, actinic keratosis. I'll share information on that. Be sure to take the survey as you're leaving tonight, and if you are available, stay on for an additional 5-10 minutes. My colleague Mike Benanzi is going to do just a quick demo of visual DX and how that can be helpful in treating acne, AK, and really any type of diagnostic question that you come in contact with. So we are so thrilled to be offering these educational webinars, not just in 2021 and 2020. And we really see this as doing something beyond. Obviously, I want to thank our sponsor, Almirall, for their support in helping us provide these. But it's really because of you all that attend and help us make this possible. So let's just wait, maybe 1 or 2 more minutes, and then we'll get started. Again, it's best if you can use both your phone and a computer if possible. It's just easier to take the quiz that way. So with that said, I'm going to go on mute and I will start this for you. And then at the end of this, again, we'll recap what's coming up next, and I'll hand it off to my colleague, Mike Benanzi. So let's get started. Okay, well, not sure what happened on that last question. We might not have enough time to answer, but congratulations to our winner for this evening, H. Stell. So I will be in touch with you to get you your gift card. I am going to just for 1 second stop my share so that I can also share with you what's coming up next, and then I'll turn it over to my colleague. So coming up next on April 27th, we have our next webinar. It'll be Actinic Keratosis, Advances in the Management of Field Cancerization. To register, you can go to visualdx.com/AK webinar. We also keep all of our events at visualdx.com/events, which I'll put in the chat, as well as the one for the next webinar. And our guest presenter for that will be Dr. Bunick from the Yale School of Medicine. So on that note, again, thanks everyone. I'm going to turn it over to my colleague, Mike Finanzi, for those that would like to stick around and have a short demo of Visual DX. So thank you so much.
Thanks, Kim, and thanks, Dr. Graber. Thanks so much, everyone, for the opportunity. Over the next couple of minutes here, I just want to present Visual DX to you and demonstrate how it's utilized in the clinical setting on the web version. What you're looking at right now is Visual DX. On the web, you can utilize this on your Android device as well as your Apple device. In the simplest approach to Visual DX, you can look up any diagnosis. We've got over 3,200 diagnoses within Visual DX. If I just apply what Dr. Graber had just presented, if we looked up acne, for example, we can look this up in both the child and an adult. That does adjust the content as well as the images that you see on each page. But what we're going to provide you with is a quick synopsis, really written in paragraph form, intended to be utilized at the point of care. Very concise. We've got some billing codes, things to look for, diagnostic pearls. We have a nice differential diagnosis and pitfall section with hyperlinks, best test, how to manage, and then your therapy options at the very bottom of the page. One of the things that Visual DX is well known for is our image collection. We have arguably the world's best collection of medical images that we've been collecting for over 2 decades now. And with that, you have the ability to filter the images. So when it comes to patient engagement, you can easily pivot, filter the images, and then adjust it to the skin pigmentation that might best represent your patient. So if you want to adjust it to a type 4, 5, or 6, you can even get to the specific body location as well. And then you can go right in and demonstrate how that picture looks and best represents that patient. The other approach to Visual DX is the forward-thinking approach, where you're not quite sure what the diagnosis is, but you've got a chief complaint and you want to build off of that to get to a differential through a guided workup. So what you can do is you can start off by either typing in a chief complaint in the search bar here, or you can also click one of these icons where you'll be prompted to select one of the chief complaints. So if we select a rash or multiple skin lesion, we can select that, and then we'll be going through a guided workup to add additional findings where we'll ultimately view the differential. On the right-hand side, we can adjust the patient's general age and gender at birth. And then as we go through here, we can select the different types of skin lesions. As we go into, let's say, smooth papule or smooth plaque, we can click the plus signs and get a quick definition of what they, how to properly define them. And then if we want to select one of them, we can do just that, move it over to the right-hand side here, and then continue to go on and add more findings. We can select the body location. So if you're finding that it's on the trunk, any signs or symptoms, we can say there's some itch and some fever, appearance of the patient is ill, and then once we feel comfortable enough, we can view the differential. When we view the differential, what we're going to do is we're going to weight that in a format that has the highest matches at the top, and then so on as you go down, it's less and less. You can see a drug eruption, herpes zoster, matching 6 of 6. If I go to sarcoidosis, again, matching 6 of 6. If I go down to measles, for example, it's matching 5 of 6. itch being crossed off. If I wanted to go right into the article, I can just do as I did before with acne, view the article, look at the images, get a quick synopsis, treatment options, therapy. All of that is included on each page. The final approach to Visual DX is the drug reaction data that's available. So you can type in any medication coupled with a complaint from that, and you'll be able to view all of the publications that link to that. So if I do Doxycycline, for example, and I want to select, I want to see if there's any citations linking to abdominal pain, like Dr. Graber had mentioned. And I type just abdominal pain, and we can keep the patient's age and gender, just like that. The machine learning will kick in, and it'll go automatically to the drug induced tab. You can see in the lower right corner here, these citations are linking doxycycline to each of these diagnoses listed here. So you can see if I look at drug induced abdominal pain, there's 5 citations linking to doxycycline. If I click that 5, you can see those PubMed articles, and you can have a direct link to that publication. If I wanted to go into the article, I can do as I did before. I can even select the drug reaction data and view all of the other medications in alphabetical or numeric order. If you do have any questions about Visual DX or are interested in learning more about our group and institutional rates, you can certainly go to visualdx.com/meet. Goes directly to my Calendly calendar, where we can schedule just a brief 15-minute chat to learn more about how we have our licensing options for, again, the group and institutional level. At Visual DX, we're licensed in over 2,300 hospitals and large clinics around the world, and we are also in over 50% of the medical teaching institutions across the U.S. So with that, I really thank you for your time and appreciate the opportunity. Thanks so much to connect with y'all, and Kim, thanks so much for hosting.
Thank you, Mike, and thanks again to Dr. Emmy Graber, and we hope you all have a wonderful evening. Make sure you fill out the survey. Always give us feedback, especially on topics going forward that you'd be interested in having us host. With that, I hope everyone has a wonderful evening. Goodbye.